Lungs. Uh, Is it Wegener's sinusitis? Because involvement of like kidney, involvement of sinus, and there may be lung involvement too, as we are doing respiratory system. Maybe, I don't know. Yes, it's an antibody. Is vasculitis. Okay. Now, this patient with Pianka Sianka, like in Wegener antibody. Okay. This patient with recurrent sinusitis, otitis, and auditory canal ul- ulceration, fatigue, anemia, microscopic hematuria, likely has GPA, formerly known as Wegener's, a small or medium vessels, medium-sized vasculitis. The upper respiratory tract is commonly involved, resulting in bloody or purulent discharge, oral or auditory canal ulcer, sinusitis, hearing loss, saddle nose deformity. Lower respiratory tract involvement not clearly seen in this patient may cause dyspnea, cough, hemoptysis. Systemic symptoms, fever, arthalgia, weight loss, fatigue are common. Lab studies often demonstrate mild leukocytosis and anemia as seen in this patient. Renal involvement in the form of glomerulonephritis and can be delayed from initial presentation and results in hematuria, non-nephrotic range proteinuria, and renal insufficiency that can be rapidly progressive. Serum ANCA anti-neutrophil cytoplasmic antibody should be checked in all patients with suspected GPA, high sensitivity and specificity. Proteinase 3 ANCA, also known as C-ANCA, proteinase 3 ANCA, also known as C-ANCA, is most commonly positive in GPA. Myeloperoxidase ANCA, P-ANCA is sometimes positive, although it is more commonly positive in other ANCA-associated vasculitis, microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis. HIV can increase the chance of false positive ANCA results and should be ruled out. Patients with clinical preparation and ANCA studies consistent with GPA and may be initiated on therapy, high-dose corticosteroid with immunomodulators, cytotoxic agents prior to confirmatory biopsy. Yes. So Wegener, like GPA, the granulomatosis with polyangiitis, upper respiratory uh, sinusitis, otitis, saddle nose, lower respiratory lungs, nodules, cavitation, interstitial lung disease, diffuse alveolar hemorrhage, and kidney. Rapidly progressive glomerulonephritis, skin may cause livid reticularis, a non-healing ulcer. ANCA PR3 MPO biopsy, skin leukocytoclastic vasculitis, kidney pus immune glomerulonephritis, and lungs GPA granulomatous vasculitis, corticosteroid and immunomodulator cyclophosphamide. Next. Okay. This patient being treated for asthma exacerbation now has leukocytosis with neutrophilic predominance, which is a common side effect of systemic glucocorticoid methylprednisolone. Glucocorticoid can cause leukocytosis due to the following: mobilization of the marginated neutrophil, into the bloodstream, predominant mechanism. Marginated neutrophil are attached to the endothelium of blood vessel. Glucocorticoid induced mobilization of these neutrophil leads to higher number of circulating neutrophil, stimulation of release of immature neutrophils from the bone marrow, as evidenced by 3% band forms in this patient, and inhibition of neutrophil apoptosis. In contrast, glucocorticoid decrease in number of circulating lymphocytes and eosinophil through a combination of increased apoptosis, increased immigration into the tissue, and decreased production. Cortisol, yes. Is it like parasitic infestation, parasitic infection? It is, oh, 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 It is adrenal insufficiency. Yes, yes. Adrenal insufficiency causes eosinophilia, high neutrophil. Okay. Common manifestation of superior pulmonary sulcus tumor. There may be shoulder pain. This patient has arm pain, shoulder pain, Horner syndrome, invasion of the paravertebral sympathetic chain or stellate ganglion, ipsilateral ptosis, meiosis, enophthalmos and hydrosis, neurologic symptoms in the arm, invasion of C8 to T2 nerves, weakness or atrophy of the intrinsic hand muscle, pain or paresthesia of the fourth and fifth disease and medial arm or forearm, and weight loss. This patient with weight loss, dry cough, arm pain. This patient with weight loss, dry cough, arm pain has imaging evidence of superior sulcus or Pancoast tumor. Pancoast tumor occur in the apical pulmonary groove and are generally caused by adenocarcinoma or squamous cell carcinoma of the lung. Smoking is the single greatest risk factor. Smoking is the single greatest risk factor. Manifestation generally arise when the tumor compresses and invades adjacent structure. Shoulder pain due to invasion of the brachial plexus, pleura, ribs, vertebral bodies. Because shoulder pain is common and often due to benign cause osteoarthritis, the diagnosis of the Pancoast tumor is frequently delayed. Horner syndrome meiosis, Horner syndrome meiosis, ptosis, and hydrosis due to invasion of the paravertebral sympathetic chain or the stellate ganglion. Neurologic manifestation, weakness or atrophy of the hand muscle, paresthesia, pain in an ulnar deviation due to invasion of the inferior portion of the brachial plexus, and hoarseness due to recurrent laryngeal nerve invasion and supravenous syndrome. Weight loss is common, and pulmonary symptom cough do not typically occur until the tumor is large. Okay, sorry. Okay, bronchial carcinoid tumors are rare and usually occur centrally in the central airways, not the lung apex. Most cases present with hemoptysis, cough, dyspnea from denudation, obstruction of the airway, cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. Look at the picture. There is multifocal patchy consolidation on contrastivity and ground glass opacification. Causes dry cough and systemic symptoms that last for months. Cross-sectional imaging usually demonstrate ground glass opacity, typically bilateral rather than a solid mass. Mesothelioma is a malignant neoplasm derived from mesothelial lining of the thoracic cavity. It is strongly linked to asbestos. It is strongly linked to asbestos exposure and usually presents with cough, chest pain, dyspnea. Chest imaging typically reveals pleural thickening with an infusion. Pleural thickening with an infusion. Mesothelioma. Adenovirus. This is yes. Okay. Mass. Look at the endobronchial carcinoid. Yes. Okay. So there is mass, then bronchiectasis with impacted secretion. There is also bronchiectasis with impacted secretion and segmental primary artery. Okay. These patient, wait. Okay, this patient presents hemoptysis, radiographic findings mass more than 3 centimeter, radiographic finding mm, mass more than 3 centimeter, significant contrast enhancement concerning for malignancy, although common forms of lung cancer, squamous cell carcinoma, adenocarcinoma do not typically occur in young smoker, do not typically occur in young smoker. Young non-smoker. These individuals occasionally develop lung cancer due to bronchial carcinoid. Bronchial carcinoid is a neuroendocrine malignancy derived from the Kalchiski, that is enterochromaffin cells, in the bronchial epithelium. It is typically forms in the proximal airway and presents with bronchial obstruction, wheezing, dyspnea, recurrent pneumonia in the distal lung, or tremor, bleeding, hemoptysis. CT scan of the chest usually reveals avid contrast enhancement, avid contrast enhancement due to highly vascular nature of the tumor, and endobronchial component due to extension of the lesion into the bronchial lumen. The mass can be homogeneous in appearance and have classified areas. Sorry, and have calcified areas. Bronchoscopy with biopsy is performed to confirm the diagnosis. Yes. Okay. If it is not respiratory, I will be distracted. Okay. Hello. I am saying that if it is not respiratory system, I may choose the wrong answer. Okay. This patient has systemic signs of infection, fever, confusion, tachycardia, and manifestation that localize the infection of the lung. Manifestation that localize the infection of the lungs, hypoxia, cough, right lower lobe crackles. Although these findings are classically associated with community acquired pneumonia, the diagnosis of the CAP requires pulmonary infiltrate on chest imaging. Pulmonary infiltrate on chest imaging. However, patients who are immunosuppressed prednisolone use are often unable to generate strong enough cytokine are unable to generate strong enough cytokine response to recruit the significant inflammatory cells to areas of pulmonary infection, which frequently results in minimal or no alveolar infiltrate on chest exit. These may be exacerbated by a dehydrated state, dry mucous membrane which limits fluid extravasation into the lung tissue. Therefore, immunosuppressive patients with likely CAP, immunosuppressive patient with likely CAP, who have an initial negative chest X-ray, who have an initial negative chest X-ray should undergo more sensitive pulmonary imaging with high resolution CT scan of the chest. This test is better visualizes the pulmonary parenchyma and can typically identify subtle pulmonary infiltrate, thereby confirming the diagnosis of the CAP. Okay. Okay. This patient is recovering from acute exacerbation of the COPD. Hypoxemia is a common hypoxemia is common in patients with advanced COPD. Multiple studies demonstrate survival of the long-term home oxygen therapy. L-TOT patient with significant hypoxemia. L-TOT patient with significant hypoxemia. The mechanism of mortality reduction is unclear but could be related to revealing hypoxic pulmonary vasoconstriction to protect the right ventricle against pulmonary hypertension group 3 or core pulmonary. The criteria for initiating L-TOT in patients with chronic hypoxemia is arterial oxygen PaO2 is less than 55 millimeter less than 55 millimeter of mercury, or oxygen saturation SaO2 is less or equal 88 millimeter of mercury on room air at rest with recent exertion or during sleep, and PaO2 less or equal 59 millimeter of mercury, or SaO2 is less than 89 millimeter of mercury in patients with core pulmonary or secondary polycythemia. Hematocrit more than 55. Exertional desaturation is common occurrence in COPD. However, L-TOT is not indicated for relative desaturation that remain more than 88%, because exercise tolerance is very unlikely can be limited by absolute hypoxemia. Okay. This it is minimal layering fluid on the lateral decubitus frame, isn't it? So why we will give like a chest tube placement? Yes, chest tube placement for moderate pleural effusion. I think that it is the patient has new. Yes, I think that mm, the patient should start antibiotic. Okay, okay. Pneumonia and effusion on chest X-ray. If there is pneumonia and effusion on chest X-ray, small effusion and no respiratory distress or hypoxia, small effusion and no respiratory, oral antibiotic and close monitoring. Moderate or large effusion or respiratory distress or hypoxia, ultrasound, IV antibiotic, ultrasound, IV antibiotic, drainage, ultrasound, IV antibiotic and drainage. These patients, okay, this patient presents with a history of radiographic findings suggestive of pneumonia and a parapneumonic pleural effusion. Pleural inflammation secondary to bacterial pneumonia can lead to leakage of exudative fluid in the pleural space. Patients may present with symptoms of bacterial pneumonia, fever, cough, and examination usually reveals focal rales decreased or absent breath sound or dullness to percussion. Children with a small effusion may be breathing comfortably with normal vital signs, although those with moderate or lower effusion typically exhibit signs of respiratory distress, grunting, nasal flaring, submucosal retraction, tachypnea, and hypoxia. Although the diagnosis can be suspected from history and physical examination, chest X-ray confirms the presence of pleural fluid obscuring the costophrenic angle, layering fluid on lateral decubitus frame for small pleural effusion in patient without respiratory distress such as this. Patient management include oral antibiotic, close follow-up and outpatient basis. Close follow-up on outpatient basis. Okay. Sorry, it is not pericarditis. Maybe empyema. Okay, although, sorry, approximately 40% pneumonia are associated with pleural effusion. Most are small, free-flowing. Most are small, free-flowing, sterile, resolved with antibiotic, uncomplicated parapneumonic effusion. However, if the bacteria persistently cross the infected parenchyma, however, if the bacteria persistently cross the infected parenchyma into the pleural space, a complicated parapneumonic effusion, or empyema can develop. Both empyema, uh, both empyema and complicated parapneumonic effusion are marked by large, often loculated effusion, typical thoracosynthesis abnormalities, low pH, low glucose. Unlike complicated parapneumonic effusion, empyema have no frank pass or bacteria gram stain in the pleural space. This patient likely has pneumonia, fever, productive cough, the presence of pleuritic chest pain, large left-sided pleural effusion suggests of pneumonia is complicated by empyema. Risk of pneumonia complications such as empyema is greater in antibiotics who are immunocompromised HIV post-transplant. All empyema and may complicated all empyema may many complicated pneumonic effusion require prolonged antibiotic 2 to 4 weeks and drainage usually with a chest tube. Okay, is it ARDS? Okay, okay, drowning injury. Okay, drowning defined as respiratory impairment due to submersion in liquid, due to submersion in liquid is leading cause of accidental death in children. Children often less than children age less than 5 are increased risk due to inadequate supervision around pools, bathtubs. Male age 15 to 25 are also high risk due to risk-taking behaviors and concomitant drug or alcohol use. Complications of drowning are a result of hypoxemia from fluid aspiration. The aspirated liquid washes out the pulmonary surfactant, increases alveolar capillary membrane permeability, which tends to development of non-cardiogenic pulmonary edema, respiratory insufficiency, and ARDS. Signs and symptoms of the ARDS: dyspnea, wheezing, crackles, cyanosis typically begin within first 8 hours, and respiratory insufficiency can progress insidiously over 72 hours after the initial event. Therefore, despite currently being asymptomatic, this patient is still at risk for ARDS. All patients with a non-fatal drowning event, even with normal vital sign examination findings should be admitted to the hospital for cardiopulmonary monitoring for at least 8 hours. In this case, the patient has excellent prognosis because she was submerged briefly and resuscitated quickly and is now back to the baseline activity. Next, if somebody comes with sickle cell and if there is infection, what should give antibiotic blindly? Because uh, sickle cell patient uh, has autosplenectomy, there may be autosplenectomy in sickle cell patients, so chance of having capsulated organism to infect. So that's why for preventing the infection of preventing the infection of the capsulated organisms like shine, we give antibiotic as early as possible. Okay. So this patient with sickle cell disease has a respiratory symptom, fever, new infiltrate on chest X-ray. These findings are consistent with acute chest syndrome, a potentially fatal complication of sickle cell disease. Acute chest syndrome is common in children but can occur at any age with the higher mortality rate in adults. Acute chest syndrome can occur with fever, hypoxia, chest pain, and respiratory symptoms. Dyspnea, tachypnea, wheezing, cough in patients with sickle cell disease. In patients with sickle cell disease, any one of these symptoms in conjunction with new infiltrate, any one of these symptoms like dyspnea, tachypnea, wheezing, cough, any one of these symptoms along with a new infiltrate on the chest X-ray confirm the diagnosis. Pathogenesis involve vaso-occlusion of the small pulmonary vessels, which in adults typically due to fat embolus that arises from the bone marrow infarction despite bone marrow infarction during an acute pain crisis. Pneumonia is a common trigger of acute chest syndrome but is clinically indistinguishable from it. In this patient, the lack of reticulocytosis and of preceding bone pain make pneumonia more likely because chest syndrome acute chest syndrome cannot be excluded. Initial treatment of acute chest syndrome includes IV fluid because dehydration can exacerbate sickling and analgesics, opioid, non-steroid anti-inflammatory drug for pain control. Because pneumonia cannot be differentiated from acute chest syndrome, prompt antibiotic therapy is also required. Empiric coverage Empiric coverage of community-acquired pneumonia include safe drugs. Prompt antibiotic therapy is required. Empiric coverage of community-acquired pneumonia include ceftriaxone and azithromycin, which target typical Streptococcus pneumoniae, Haemophilus influenzae, and atypical Mycoplasma chlamydia bacteria, respectively. Okay. Yes. Is it aspiration pneumonia? Okay, look at the option A first. Smokers and patients with cystic fibrosis have impaired mucociliary clearance, which increases their risk of pulmonary infection and bronchiectasis. However, this patient has no smoking history given her dementia, recurrent bacterial aspiration pneumonia is the most likely cause of her recurrent CAP. This patient with fever, cough, hypoxia, pulmonary infiltrate, and has recurrent community acquired pneumonia. Although recurrent CAP can be triggered by a variety of the underlying condition. Bronchial obstruction, immunodeficiency. This patient has a recurrent bacterial aspiration pneumonia due to following clinical feature. The lobe involved and the advanced dementia. The lobe involved aspiration typically introduces microbes into the dependent portion of the lung. Aspiration events that occur while the patient is upright usually affects the lower lobe, and those that occur when the patient is recumbent, bedbound, usually affect the superior portion of the lower lobe or the posterior portion of the upper lobe. Therefore, recurrent aspiration pneumonia may occur in the same lobe or different lobes depending on the portion of the patient's aspiration. Advanced dementia. Patients with advanced dementia often have trouble coordinating the muscle involved in swallowing. This frequently results in pharyngeal dysphagia, which may cause aspiration due to insufficient closure of the airway during swallowing. Patients with bacterial aspiration pneumonia present usually present several days after the aspiration event with fever, dyspnea, cough productive of putrid sputum, hypoxia, and leukocytosis are common. Although aspiration pneumonia was although aspiration pneumonia was previously thought to frequently involve anaerobic bacteria, more recent data indicate that anaerobes are present in a small minority of the cases. Therefore, empiric antibiotic is geared towards the aerobic upper respiratory organism when no empyema or lung abscess are present. Treatment of aspiration pneumonia is same as the community acquired pneumonia like ceftriaxone plus azithromycin. Okay. This patient with chronic production of a voluminous or thick sputum, wet crackles that clear with coughing, suggestive of stagnant, viscous secretion or mucostasis, and recurrent sinopulmonary infection, now presents with worsening hemoptysis. The presentation is highly suggestive of bronchiectasis, a disorder characterized by vicious cycle of infection and inflammation resulting in airway dilatation. Mucostasis promotes bacterial overgrowth, perpetuating the cycles of infection and inflammation. Chronic airway chronic airway wall inflammation leads to submucosal erosion, producing bronchial arteriolar bleeding that ranges from chronic minimal streaking to acute life-threatening frank hemoptysis. Worsening hemoptysis may indicate an exacerbation or of bronchiectasis. In most instances, treatment of superinfection, antibiotics, and mucus retention airway clearance mucolytics reveals hemoptysis. However, bronchoscopy and bronchial artery embolization is occasionally necessary for severe cases. In this patient, bronchiectasis should be confirmed. In these cases, bronchiectasis should be confirmed with high-resolution CT scan and underlying causes. Immunodeficiency, hypogammaglobulinemia should be sought. Respiratory cultures are indicated to assess for superimposed infection as the trigger for worsening hemoptysis to tailor antimicrobial therapy. Yes, bronchiectasis. Pathophysiology is airway insult with impaired clearance, mucostasis, and immunodeficiency. Chronic is daily production of voluminous, thick, with or without blood tinged sputum. Acute exacerbation, recurrent infection with mucopurulent sputum, with or without frank hemoptysis. Etiology is airway obstruction, cancer, foreign body, and mucostasis, like cystic fibrosis and ABPA. Immunodeficiency, decreased immunoglobulin, autoinflammatory disease, Sjogren's syndrome, chronic or past infection, mycobacteria, or toxic inhalation. HRCT, high resolution CT scan of the chest needed for diagnosis, where we will find airway dilatation. Pulmonary function tests show obstructive pattern and investigation of etiologies, immunoglobulin level, respiratory culture, bronchial obstruction. Address underlying disorder, immunoglobulin replacement, airway clearance, chest physiotherapy, mucolytics, antibiotics to suppress bacterial overgrowth and treat exacerbations. Okay, this is transient tachypnea of the newborn, retained fluid, retained fetal lung fluid. Risk factor is cesarean birth, prematurity, maternal diabetes. Clinical finding tachypnea, increased work of breathing, tachypnea, increased work of breathing, clear fluid, clear breath sound, chest x-ray show hyperinflation, fluid in the fissure, supportive care, oxygen, nutrition, and self-resolution in 1 to 3 days. This term newborn with increased work of breathing and fluid filled fissure has transient tachypnea of the newborn (TTN), a condition caused by delayed resorption and clearance of the pulmonary fluid. Normal alveolar normal alveolar liquid produced during lung involvement is later absorbed by mature fetal lungs into the interstitial space and ultimately pulmonary vasculature. The resorption is driven by increased catecholamine signals in the late gestation, markedly increases during labor. Therefore, patients born prematurely by caesarean delivery are at risk of TTN. Excess pulmonary fluid can cause respiratory distress, tachypnea, grunting, retraction, and hypoxia in newborn in the first few hours after delivery. Breath sounds are often clear in patients with TTN, as most of the fluid is interstitial space in the rather than in the alveoli. Findings of chest X-ray. Findings of chest X-ray hyperinflation. Findings of chest X-ray hyperinflation fluid in the alveolar fissure confirm the diagnosis, and patients are treated supportively. Supplemental oxygen. TTN usually resolves TTN usually resolves within a few hours to days as passive fluid resorption is complete. Okay. Uh, Eosinophil count is higher. It's not preeclampsia. That only makes sense. It is not sarcoidosis. It is due to nitrofurantoin. Right. Okay. This patient with new onset shortness of breath. This patient with new onset shortness of breath, fever, dry cough, and mild, bilateral mid and lower lung opacity likely has acute nitrofurantoin induced pulmonary injury, acute nitrofurantoin induced pulmonary injury. Both short and long term use of nitrofurantoin can cause lung injury. Short term use is associated acute case of hypersensitivity include lungs, whereas long term use can cause interstitial lung disease. In acute disease, there is commonly delay in 3 to 9 days from medication initiation to the onset of symptoms. Examination reveals bilateral crackles. Imaging demonstrate bilateral basilar opacities, and erythematous macropapillary rash may be present. Pleural effusion can occur unilateral. The diagnosis is based on characteristic symptoms, suggestive lab findings, leukocytosis, eosinophilia imaging, and the timing of nitrofurantoin exposure testing to exclude other diagnoses, pneumonia and heart failure can be considered. Patient involves cessation of the drug, which typically leads to symptomatic improvement within 1 to 2 days. 2 days. Okay, this patient's presentation is most consistent with lung cancer with extensive smoking history, hemoptysis, hypercalcemia, hilar mass, raising strong suspicion of squamous cell carcinoma of the lung. Most cases of a squamous cell carcinoma of the lung arise in the central portion of the lung. Therefore, initial presentation as hilar mass. Initial presentation as hilar mass due to squamous metaplasia, dysplasia, and carcinoma in situ within the central tracheobronchial tree. Patients generally present with cough, dyspnea, and hemoptysis due to erosion of the airway mucosa. Smoking is the single greatest risk factor. SCC is associated with hypercalcemia of the malignancy due to release of parathyroid hormone related peptide which binds to the PTH receptor in the bone and in the distal tubule of the kidneys increases calcium reabsorption. Common manifestation hypercalcemia include anorexia, constipation, renal dysfunction, nephrogenic diabetes insipidus, and escaping. Hypercalcemia of malignancy is generally due to either osteolytic bone metastasis or the release of parathyroid hormone related peptide. Differentiation can be made with whole body scan and parathyroid hormone related peptide testing. This patient normal whole body scan, no metastatic bone lesions indicate the source of hypercalcemia. Source of hypercalcemia is parathyroid hormone related. Is it hemothorax? Okay. Mm. Oh, this patient has hypotension, tachycardia, flat neck veins, flat neck veins despite fluid resuscitation, 3 liter normal saline consistent with hypovolemic shock in the setting of trauma, unrestrained passenger in a motor vehicle collision. Hypovolemic shock is attributed to hemorrhage until proven otherwise. A source of bleeding should be sought with special attention directed towards a compartment that can conceal massive traumatic hemorrhage. the chest, abdomen, pelvis, including retroperitoneum and the thigh. These patients show left-sided. This patient shows left-sided diminished breath sound, dullness to percussion, most persistent with hemothorax. Hemothorax may result from injuries to a larger intrathoracic structures, aorta, hilar vessel, and smaller structure that is lung, parenchyma, intercostal blood vessel. Each hemothorax each hemithorax can hold 40% of the circulating blood volume. Massive hemothorax more than 1500 ml can present with signs of hemorrhagic shock, tracheal deviation from mass effect. Tube thoracostomy should be performed with immediate bloody drainage more than 20 ml per kg, being an indication of emergency surgical thoracotomy. Okay, sorry. Yes. Is it looks like pleural effusion, right-sided? Sorry. Do not look at the tactile centers. What would be the percussion mode? Okay. Oh, sorry. And vocal fremitus or tactile fremitus will be decreased. Yes, maybe yes. And it is increased only in one condition, like in consolidation where there is pneumonia. Tactile fremitus, sorry, tactile fremitus, one of the what we do in case of seeing the vocal fremitus, we just put our hand on the like in between third or fourth rib or fourth, like in the ribs. Then we tell the patient to say 99 or 11. If it vibrates or it's a one form of feeling, like what can I say? It is tough, but it can be felt in the hand. That is tactile or vocal fremitus. So, sorry, tactile fremitus or sorry, yes, it is increased in lower. In tactile fremitus, there are two things like vocal tactile fremitus and vocal resonance. Like tactile fremitus is a feeling, like in consolidation, it will be increased. And for pleural effusion, as As in pleural effusion, what is present in the lung? It is the water is present in the lung. So when you say something like 99, the word goes and it resonates from the water and then it comes into our hand. So if you throw something in the water, it will just dive into the water. And if there is like solid thing, like in consolidation, there are something in fluid and as well as a solid thing. So a vibration would be much more. I do not know you understand or not. If like vibration, think like a ball. You are throwing a ball into the wall and it will come into your hand. But if you throw your ball into the water, it will not gonna come. So in pleural effusion, there is fluid, so it the vibration or the thing will not gonna come. You can think in that way. Okay. This patient's chest x-ray this patient's chest x-ray reveals right-sided pleural effusion, fluid layering, obscured costophrenic angle that, given her history of breast cancer, raises concern for a malignant diffusion due to breast cancer recurrence. Physical examination finding can be helpful in differentiating the lung pathology, especially consolidation and pleural effusion. Breath sounds represent air movement within the lung, and tactile fremitus is caused by vibration that occurs during the air movement. In general, sound and vibration travel faster and more efficiently in the solids than the liquids, more efficiently in solids or liquids than in air, which results in increased intensity of the breath sounds and increased tactile fremitus in patients with consolidative process inside the lung. Bacterial pneumonia, however, if fluid uh, pleural effusion or air pneumothorax are present just outside the lung in the thoracic cavity, they can act to insulate sound and vibration originating from the lung, which leads to decreased breath sound and decreased tactile fremitus. Dullness to percussion occurs in the pleural effusion and lung consolidation due to an increase in tissue fluid density compared to the normal air fluid level. Hyperresonance to percussion is characteristics of air fluid thoracic cavity pneumothorax or hyperinflated lung tissue. Okay, okay, can we stop today? Okay, no.